Good morning, everyone. Thank you for being here. Dr. Rice, thank you for the introduction and the kind invitation to present in today's seminar series. I'm going to begin my presentation by sharing with you a short story. So a few years ago, I participated in my annual screening for breast cancer. So I had a mammogram. I received a call from the facility indicating that I needed to come back because I guess they saw something and wanted a closer look. I know this happens commonly, and so I really wasn't concerned. I was my usual go-lucky self, and so I went back to the facility, and I sat in the waiting room as I always had. Now, when you have a screening mammogram at this facility, you always go into the right door. So the door on the right is where you enter. So when it was my turn for this additional testing, I kind of assumed I was going to go into the right door. When they called my name, I was directed to go into a different door, the door on the left. I was still my happy-go-lucky self, but I started to wonder a little bit because I was now going in a different door. So I went into this other screening facility, and unlike when you have a screening mammogram where you get into your gown and you go directly into the room to get screened, in this side of the facility, you got into your gown, you put your clothes in a plastic bag, and you came back to a common waiting area with other women. So that's what I did. As I sat there with the other women, we started to talk, we said hello, I started to have conversations, and then they started to talk about their breast cancer and their treatment and their participation in clinical trials. And all of a sudden, the little anxiety that I had grew into a lot more distress because I was not expecting those conversations. And as a researcher, I know there are individuals who study trust in the healthcare system and how patterns of trust may vary across different racial and ethnic groups. And I've always been someone who very much trusts the medical system. But not expecting the conversations and be sitting in a room with women who were diagnosed with breast cancer, as I came back for some additional testing, I began to wonder, is there something that they're not telling me? I then proceeded to get up, and I went to look outside the window, and I had my gown on, still waiting for my diagnostic evaluation. I had my clothes, my plastic bag, and I was amazed at how quickly my thoughts started to lead to thinking about my life. What happens if I did have cancer? What regrets do I have? What birthdays did I miss or anniversaries did I miss because I lived geographically distant from my family? You begin to do this life review, you begin to think about your priorities, and remember still at this point, I'm only going through a diagnostic evaluation. Imagine what it's like for individuals who are diagnosed with cancer. How many different emotions they go through. One of the things that was nice about this facility is that after you do your diagnostic evaluation, they tell you right away how things are looking. And so they told me everything looked fine. So I was elated. But then they said, you need to come back in 6 months. So once again, my distress began to increase. So over the period of just an hour, I went through happy-go-lucky, slightly anxious, very distressed, reviewing my life, elated, confused, maybe some issues of trust. Imagine what it's like for the cancer journey when it's months, when it's years, dealing with cancer. Over the next 40 or 45 minutes, what I would like to do is share with you a glimpse of that journey based on some of the work that I've done with my colleagues. In the first part of the presentation, I'm going to talk about the Cancer Cares Outcomes Research and Surveillance Consortium. I'm going to first introduce to you what that consortium focused on and then share with you some papers that we did from that study. In the second part of the presentation, I'm going to talk about the new center that I've established, sharing with you its mission, history, context, and introducing you to the team. So the CANCURS program is a research program to understand treatment choices and outcomes of colorectal cancer and lung cancer patients. The context of this study was that for many Americans with cancer, there's a wide gulf between what can be construed as the ideal and the reality of their experience with cancer care. And although this was stated in 1999, we can say that this continues to be true today. Further rationale for the CANCOR study is that there's disparities in cancer care and outcomes by patient's race, age, and by provider, and that the causes of these gaps and disparities are poorly understood. It was established in 2001, funded by NCI and the Veterans Administration, and is a cooperative agreement with independent investigators throughout the United States. It had a broad range of expertise included in this consortium. The next slide shows the different areas in which we partnered to recruit patients with cancer. And at the University of Alabama at Birmingham, Dr. Mona Fouad was the PI, and this is where the work emerged. The next slide shows the CANCOR's conceptual model. And as you can see from this slide, we measured many things, a number of patient factors, including traditional demographic factors, but also health behavior, social support, community characteristics. We collected information from providers. We collected information on the processes of care, psychosocial support, end-of-life care, symptom management. We examined the organization of the healthcare system in which patients were receiving their cares, and we had a number of outcomes, including survival, cancer morbidity, and treatment complications. Patients were recruited from these sites, and patients were involved in the study in various aspects, but we recruited over 10,000 cancer patients. So for the first set of papers that I'll discuss, these are papers that I led as the first author. I will discuss them in great detail. The first paper will examine what patients worry about when making decisions about their cancer treatment. The second paper will highlight the variation in the caregiving experience. And the third paper will highlight willingness to trade personal financial resources for life-prolonging cancer treatment. The next two papers are papers on which I am a co-author. I'll present these in less detail, but really focus on highlighting the results. The first paper will examine depressive symptoms and psychosocial service use, and the last paper, the economic burden of cancer. So the first paper is titled, "What do cancer patients worry about when making decisions about treatment? Variations across racial and ethnic groups." So the background for this paper is that making treatment decisions about cancer can be stressful for patients. Previous research has examined concerns related primarily to treatment side effects. We know little about the more practical concerns that patients worry about. And as we know, oftentimes those practical concerns are concerns that may make it difficult to adhere to recommended treatment. The objective of this paper was to determine what concerns patients have when making these decisions. So the question we asked was, at the time you were making decisions about your treatment for your lung or colorectal cancer, how much were you worried about each of the following? Would you say that you were not at all worried, a little worried, somewhat worried, or very worried about treatment side effects, treatment cost, time away from family, time away from work, and transportation to treatment sites? And I should share with you that we recruited patients about 4 months after diagnosis. So this is when the question was posed. For the analysis, the worry variable was dichotomized to reflect that some level of worry was an unmet need. Patients who indicated that they were a little worried, somewhat worried, or very worried were collapsed into a single group labeled worried, and the others were categorized as not worried at all. The reason for this approach was more than 50% of participants responded not at all worried for 3 of the 5 dependent variables. Understanding that worry could co-vary across a number of dimensions, we controlled for sociodemographic variables, which included gender, age, number of individuals supported by income, adequacy of savings. Clinical and health status variables, which included cancer type, comorbidities, health status, cancer stage. And psychosocial variables, which included perceived life expectancy, belief that cancer is curable, perceived quality of care, and social support. So in looking at our sample of just over 5,000 individuals, you see that the predominant worry centered around side effects. That being said, there was also considerable worry across other life domains, including cost, time from family, time from work, and for 22% of the sample, transportation. In all, about 85% of our CAN course participants had at least one worry, and some participants reported worry across all 5 domains, with Hispanics and Asian cancer survivors reporting worry across all five domains more commonly. The next slide shows the worry about side effects. It's a multivariable analysis to indicate or to reflect whether there are racial and ethnic variations in that worry. As seen from this slide, when we consider worry about side effects, there was no racial or ethnic variation. There were, however, other variables associated with this type of worry. Individuals were more worried if they had a higher income, more worried about side effects if they had a higher stage of cancer. If they perceived their quality of care was very good versus excellent, they were more worried. And if they self-assessed their own health as less than excellent, they were more worried about side effects. Individuals who were less worried about side effects were those who were older and those who did not know if cancer was curable versus those who thought cancer was. The next slide shows the worry about the cost of treatment. As seen from this slide, there was a racial and ethnic variations, with Asian cancer patients compared to whites being more worried about the cost of treatment. More worry was also associated with those with a higher stage cancer, with those who had a higher number of individuals supported by the income, and those who self-assessed their health status as very good, good, fair, or poor. So if you didn't think your health was very good, you were more worried about the cost of treatment. There was less worry if you were older, if you had higher income, if you were covered by insurance, and if you had more savings. How about when we considered worried about time away from your family? As seen in this slide, there was no racial and ethnic variation with regard to worry about time away from the family. However, we did note that there was variation across other variables. Specifically, if you thought your quality of your care was very good, good, or fair, or poor, versus being excellent care, you were worried about the time away from your family. You also were worried about time away from your family if you self-assessed your health status as very good, good, or fair, poor, versus excellent, and if you had children at home under the age of 18. You were less worried about being away from your family if you were older, had a higher income, or was unmarried. The next variable we looked at was worry about time away from work. And the significant finding we found here was that African Americans versus whites were less worried about their time away from work. There are a few variables here that were associated with worry. Those with higher income were more worried about being away from work, and those who were less worry was associated with being older and having more savings. Our final variable was transportation, and as seen in this slide, Hispanics versus whites and Asians versus whites were more worried about transportation as they made their decision about cancer care. There were also additional variables associated with worry. So more worry if you were unmarried. If you perceived the quality of your care wasn't good, you were more worried about transportation, and you felt that your health wasn't as good. There was less worry if you were older and if you had a higher income. So what do we know, think we know, and need to know about the worries that patients may have when making decisions about cancer treatment? We know that there's a variation in the pattern of worry by race and ethnicity. that the predictors of worry vary across worry domains, and that age and perceived quality of care are particularly important. The latter is very interesting to me because we think about improving the quality of cancer care all the time. But for individuals, for example, who perceive that the quality is not good, they are worried about being away from their families. I think that's an area of further exploration. What we think we may know is that worry may shape the cancer experience. What we need to know is what role does cancer worry have as one navigates the cancer experience, what aspects of cancer care do patients use to inform their assessment of quality, and how is that related to influencing worry? And how do we easily assess and provide support for those who are worried? The next paper speaks to the racial variation in the cancer caregiving experience. We know that cancer care continues to shift from the hospital to outpatient settings, meaning that caregivers have to assume additional duties and care for their loved ones. Caregivers report many unmet needs, including oftentimes feeling that the healthcare system essentially ignores them. They frequently aren't asked how are they doing, despite caring for the loved one and having a lot of pressure. The objective of this paper is to better understand the caregiving experience of African American and white caregivers. Patients in the CanCOR's study nominated someone who is most likely to care for them should they need it, and caregivers who provided care related to the patient's current diagnosis were included. The samples consisted of caregivers within the first year of the care recipient's cancer diagnosis and those identified after the first year of diagnosis. We mailed a survey to caregivers, and they completed the survey that assessed a number of domains listed here, so demographic information as well as contextual information, such as the own caregiver's health status. We got a sense of their instrumental activities of daily living and how much care they're providing for their loved one in that regard, as well as their activities of daily living, such as bathing. We asked the number of hours they spent caregiving and the number of clinical tasks, example, monitoring symptoms, that the caregiver performed. We also looked at caregiver resources, so the receipt of training to perform caregiver tasks, how prepared they felt for the role, how confident they were in the role, and the perceived social support. We used the analysis of covariance to compare racial groups on objective burden and caregiving resources while controlling for covariance. So what are our results? Our results indicate that there is a significant difference between the number of hours that caregiving is provided by race. As you see from this slide, within the early phase of the cancer caregiving period, African Americans are spending over 26 hours caring for their loved ones compared to 18 hours for whites. In the latter phases of the caregiving experience, African American caregivers are spending almost 32 hours providing care to their loved one versus 17 hours among white caregivers. In the earlier phase of caregiving, we know that African Americans report greater preparedness for the role. In the later phases of caregiving, we know that they have more social support and perform more instrumental activities of daily living. So what do we know? We know that racial and ethnic variation in the cancer caregiving experience exists. We know that the level of support provided by African Americans approximates a full-time job. What we think we know is that African American caregivers may be well positioned to successfully navigate caregiving because of more social support and preparedness for the role. However, what we need to know is the higher levels of social support and preparedness protective for African American caregivers? And how do we support caregivers to provide the best care for their loved ones and ensure that as a caregiver, they remain well? The last paper that I'll present in some detail is one titled Racial Variation in Willingness to Trade Financial Resources for Life-Prolonging Cancer Treatment. The background is that minority patients receive more aggressive care at the end of life, but it is unclear whether this trend is consistent with their preferences. The objective was to assess the preference for life-sustaining treatment across racial and ethnic groups of cancer patients. So we posed this question to patients. Again, this was individuals who were about 4 months post-diagnosis, and so this was a hypothetical in that they were not making this question, they're not responding to this question during a time at the end of life, but it's just shortly after diagnosis. But we wanted to understand preferences. So the question was, if you had to make a choice now, would you prefer treatment that extends life as much as possible, even if it means using up all of your financial resources? Or would you want treatment that costs you less, even if it means not living as long? We evaluated the association of race, ethnicity with preference for life-extending treatment, controlling for a number of other variables. So we controlled for sociodemographic variables that included age, gender, income, number of children in the home, health insurance, and so forth. We controlled for clinical and health status variables, cancer stage, specific diseases, quality of life, their perceived health status, depression, comorbidity score. We also controlled for psychosocial variables, social support, perceived time left to live, and a fatalism score. With regard to the perceived time left to live question, the questions posed such as, given your understanding of what the doctors have told you, your treatment, your health status, how long do you perceive you have to live? So the next slide shows the results unadjusted when we asked that question. As you can see, there are significant racial and ethnic variation. So blacks were, about 80% of blacks indicated they were willing to spend all their personal resources to extend life. 72% of Asians indicated that preference, 69% of Hispanics indicated that preference, and 54% of whites indicated that preference for life-extending care. As I shared with you, we also looked at this in a multivariable analysis. So we controlled for many, many factors. And as you can see, blacks were still more likely and more willing to expend all their personal financial resources to extend their life. When we conducted the analysis to include a comorbidity score, that finding remained. There are also additional variables that were associated with the willingness to extend life-extending treatment using up all your personal financial resources. Those who were less willing were those who were older, those who had a higher number of individuals supported by their income, and those who felt they had a shorter time to live. Those who were more willing to exhaust all their personal resources were those who were divorced or separated versus being married or living with a partner, those with a higher cancer stage, and those who perceived their time left to live was in God's hands. So what do we know, think we know, and need to know? So we know that there is racial and ethnic variation in the willingness to use all personal financial resources to extend life as long as possible. What we think we know is that patients may make trade-offs as they go through the cancer journey. What we need to know is what underlies the racial and ethnic variation in preferences. How do we reconcile the preference with the literature related to fatalism? How does this preference influence the cancer experience? And how are preferences assessed and incorporated into patient-centered care? The next two papers, as I indicate, I will present in less detail, but really focus on highlighting the results. This paper was led by Dr. Lara Traeger and is titled Race by Sex Differences in Depression Symptoms and Psychosocial Service Use Among Non-Hispanic Black and white patients with lung cancer. The objective is to examine race by sex differences in depression symptoms in adults shortly after diagnosis of stage 1 to 3 lung cancer. The methods for depression symptoms were collected via questionnaire. We also collected information on patient interest in and receipt of help for depression symptoms and psychosocial service use. The next slide shows our results collected in just over 1,000 patients. And as you can see, Black men reported the highest prevalence of depression symptoms at 24.7%, white women at 20.6%, Black women at 15.8%, and white men at 15%. The next slide shows a very interesting picture. It depicts the desire for help with one's mood and then the receipt of help for mood from the doctor. As you can see on the left-hand side, Black women had the most interest to have help with their mood at 40%, followed by Black men, white women, and then white men. The picture on the right-hand side is very different. 82% of white men received help for their mood from their physician, even though they were the group who was less likely to desire help. Then we saw that 79% of white women received help, 60 or almost 70% of Black women, and then 63% of Black men. So it's interesting to understand these relationships a little bit more. Part of the answer may come from this next graph. As you can see, there is a variety of ways in which individuals could obtain help for their mood. Black women, 45% indicated seeing a pastoral counselor. Similarly, Black women were most likely to see a social worker compared to other racial and ethnic groups. So this in part may explain the differences that we saw in the previous slide. In adjusted analysis, we see that white women remained at higher risk for depression symptoms versus Black women or white men, and that white patients were more likely than Black patients to receive the desired help as assessed from receiving that help from their physician. So what do we know, think we know, and need to know? We know that there's racial and ethnic variation in the prevalence of depression symptoms. There's variation in interest in receiving help for mood, and the receipt of help for mood from the doctor, and the pattern of psychosocial services used. So across all of those domains, there are differences across demographic groups. We may know that African men may be particularly vulnerable. But what we need to know is we need to understand how depressive symptoms manifest across racial groups. We need to understand patient-physician communication around depressive symptoms and if those conversations even occur. And we need to determine the extent to which addressing emotions may be an unmet need in this vulnerable population. The last paper I will present was led by Dr. Maria Pizu, and it's titled "The Economic Hardship of Minority and Non-Minority Cancer Survivors 1 year after diagnosis, Another Long-Term Effect of Cancer." The objective is to determine the economic hardship 1 year after a cancer diagnosis for minority and non-minority cancer survivors. And I think it's really important to think about this specific objective because we're considering 1 year post-diagnosis. So some time has elapsed since being diagnosed. Participants were flagged as having hardship if they had any of the following. So if they currently said it was difficult to live on their total household income, if they indicated that in the next 2 months they anticipated hardships such as inadequate housing, food, or medical attention, and if in the next 2 months they anticipated a reduction in the standard of living to the bare necessities of life. So this next slide shows the outcome. The very top line in this table, where it indicates economic hardship, reflects the fact that a patient indicated that they would have hardship in any of those three domains I just highlighted. And as you can see by that first column, 53% of cancer patients indicated some level of economic hardship. So again, difficulty living currently on their income, anticipating the next 2 months, they're going to have hardship as it relates to food, housing, medical attention. Anticipating the next 2 months, they're going to have to go down to the bare necessities of living. It's also very important to look at the racial and ethnic differences, particularly when we consider lung cancer. I'd like to draw your attention to the third column. Maybe I'll just come up here. Well, maybe I won't come up there. The third column here, when we look at African Americans, difficulty living on the current income. 18.7%, it's difficult or they can barely get by. 12% says it's very difficult. 7.2%, extremely difficult or impossible. Those are pretty significant numbers when we consider dealing with the cancer experience and having this economic burden in the background as you navigate this difficult trajectory. We also included multivariable analysis to see if these differences in risk remained after controlling for a number of variables. And interestingly, we found that it only remained for those who were coping with colorectal cancer, with African Americans being more likely to have economic hardship. So what do we know? That there is a substantial number of cancer survivors 1 year post-diagnosis experiencing economic hardship. What we think we know is how survivors navigate financial challenges. So we have had studies that indicate individuals may take out another mortgage on their home, they may forego medical care. But I think there's still an opportunity to more fully understand this area. What we need to know is a better understanding of why colorectal cancer yields disparities in economic burden not observed in lung cancer. And we need to expand our understanding of how economic hardship impacts life domains and decisions. So before transitioning to talking about my center, I would just like to say that I think CanCourse has given us an amazing window into the experiences of cancer patients and those who care for them. This is really rich quantitative data in which I think we're able to build upon. I think a number of qualitative studies that really seek to understand the experiences and explain some of our findings would be the next step. I will now conclude my presentation by sharing with you a few highlights for the Center for Innovation and Health Equity Research, beginning with the mission and the vision, providing a little bit of a context in which the center exists, and introducing you to the center investigators. So the mission of the center is to bring together diverse partners to collectively develop, evaluate, and implement evidence-based interventions that will be strategic and transformative in achieving health equity across the cancer continuum. I'll start with talking about the West Cancer Center, which is in Memphis, Tennessee. The doors of West Clinic opened in 1979 by Dr. William West after his mother passed away from breast cancer. The clinic started as a 2-room clinic. It's now a West Cancer Center that sees over 30,000 patients annually. Dr. West engaged Dr. Tower, who then engaged Dr. Lee Schwartzberg, and they represent the leadership of the West Cancer Center. In 2012, the West Clinic formally entered into a relationship with the University of Tennessee Health Science Center and with Methodist Hospital to form an entity that will together merge the clinical expertise of West Cancer Center and the research expertise of the university to move forward to address cancer prevention and control. So it wasn't until I moved to Memphis that I fully appreciated how West Memphis is in terms of its location in Tennessee. And so we're right beside Mississippi and Arkansas, and it's very common that patients from Arkansas and Mississippi are receiving their care at West Cancer Center. And the West Cancer Center actually has a number of locations throughout the tri-state region. So oftentimes when you think about a center, you think about the research program, which of course is important. But I also believe we have to think about the context in which the research center has been established. And there's a lot of context in Memphis. So Memphis is a city of rich cultural traditions. Music is very important in Memphis. Aretha Franklin was born in Memphis. I got to see her home one day on a tour. And so there's that rich liveliness and cultural feel to Memphis as it relates to music. We also know that Elvis Presley was in Memphis, and so you can go and see his home. You could go see the airplanes that they flew on. Again, continuing this tradition of music and innovation. It wasn't until I moved to Memphis that I realized that FedEx is located in Memphis, so it's a major economic engine for the city. We had the FedEx Forum, where our professional basketball team plays. But also very interesting culturally for me in Memphis is the pride of those who live in Memphis to continue to take Memphis to the next level, to choose Memphis. You'll see the t-shirt on the left, it says choose 901, that's our area code, so choose Memphis, Tennessee. This weekend, the little banner in the middle is from an electronic newsletter that I get each week to talk about the different events in Memphis. You see it has hashtag choose 901. I don't actually tweet or follow anyone, but last week my father, who's almost 80 years old, announced to me that he now has the internet at home. I was like, oh. I was like, oh, all right, Dad. So what are you going to do with the internet at home? And he's like, oh, I don't know. He goes, maybe I'll start tweeting. And I was like, okay. So I said, well, Dad, if you start tweeting, then I will start to follow you. And so we agreed to that. So continuing with my theme of the things we know, I know my dad's entering his 80th decade next year. The things I thought I knew is that the internet was irrelevant to him. I don't think I ever even heard him say the word internet before last week when he told me he has it at home. And I guess what I need to know is his Twitter handle since he's going to start tweeting. So, does anybody recognize this when we continue to think about context? Yes. I'm sorry. Church of God of Christ, yeah. So, yes, exactly. It's the church where Martin Luther King gave his last sermon as well, before his assassination. So again, thinking about context and the work we do, particularly when we think about health disparities. This is the Lorraine Hotel. This is where the assassination occurred. They've turned it into a civil rights museum. And if you ever have an opportunity to go to Memphis, I highly encourage you to see this museum. They've just done an amazing job with it. And this is the balcony in which he was assassinated. So we think about context, we also think about health outcomes. And so when you look at mortality per 100,000, the data that I was able to uncover, in the United States, 785.66. Tennessee is not doing as well at 961.98. Shelby County, Tennessee, where Memphis is located, 956. But look at Williamson, Tennessee, 648. It's lower than the United States. Arkansas, 965, and Poinsett County, Arkansas, 1,265. And Poinsett is probably about an hour from Memphis. Great variation in health outcomes. And I think as we think about disparities, try to understand disparities and address them, oftentimes we begin in the areas where we see the disparities to understand those barriers. But I'm also curious about Williamson, Tennessee. What's happening there that their numbers so low compared to the others? We also have to think about poverty, and it's quite prevalent in Memphis. I'll draw your attention to the last two columns. If you look at the overall poverty rate for non-Hispanic whites, it's 13%. For blacks, it's 30%. For children under 18, it's 19% for whites, 47% for children. Again, thinking about the context and where we do our work. I'd like to introduce to you the team that we're going to try to do this work with together. Dr. David Schwartz was recruited by West Cancer Center in UT to be Vice Chair of the Department of Radiation Oncology. He's also the Director of the Center for Health Equity in Radiation Oncology. His research interests includes patient-facing health informatics and community-based cancer disparities research. I was thrilled to have Dr. Shannon Christie join us this past September. She's a clinical psychologist and just recently completed her postdoctoral fellowship at Moffitt Cancer Center. Her areas of research are reducing cancer health disparities, cancer prevention and early detection, particularly colorectal cancer screening, human papillomavirus vaccination, targeted and tailored interventions, and technology-based interventions. Dr. Ilana Grazzi was actually at UT prior to my arrival, but since my arrival, we have started to work closely together, and we are celebrating her two recent awards. She has an R1 that will be a communication app to manage symptoms and improve adjunct endocrine therapy adherence, and an R21 that will examine the role of adverse symptoms and clinical response on racial disparity outcomes in breast cancer. I also have a postdoctoral student who completed his degree in experimental psychology, and his program of research includes cancer health disparities, psychosocial factors of cancer treatment and survival, and health behavior change interventions. So being in the position of directing a center has continued my journey to think about leadership. And I had the opportunity to run across this quote from a Canadian astronaut on his thoughts of leadership. And I think it very much reflects my own. So ultimately, leadership is not about glorious crowning acts. It's about keeping your team focused on a goal and motivated to do their best to achieve it, especially when the stakes are high and the consequences really matter. And I think when we think about health disparities, the stakes are certainly high and the consequences really matter. It's about laying the groundwork for others' success and then standing back and letting them shine. So I hope I'm able to do that with my center and the team of investigators that I'm working with. I'd like to end with acknowledging those who laid the groundwork for myself and letting me shine. First with my family, who created just a wonderful, nurturing environment where I could be myself and thrive and pursue my dreams. So my mom and dad, my brother and sister, my extended families, and now my wonderful in-laws. My friends, who are very much like family to me, have been with me across the journey. My mentors and colleagues at different points in life. My many colleagues, especially Maria Pizu. We said that we always had the M&M research program because, Maria Michelle. But she's an amazing friend. The staff, who's so incredibly dedicated to working hard to implement the grants and the projects and the vision that we have. The leadership at UTHC and West Cancer Center for having the vision for establishing a center and believing in me to lead it. also very much would like to acknowledge the patients, caregivers, and the participants of all of our studies. To take time out of their life to complete oftentimes many, many questionnaires, but, to share with us their hopes, their aspirations, where they struggle, where they're afraid, where they're uncertain. I mean, it's just an amazing and generous gift. And I really appreciate the time that they take with us, and am committed to being good stewards of the information they've shared with us to make things better and to improve their journeys. And then I have to thank Sherry Lamona, who's my assistant, who helped with the PowerPoint presentation and helps keep me organized and sane. And I welcome questions, and I welcome future collaborations. Thank you. Yes.
Thank you, Dr. Martin, for your talk.
You're welcome.
You had one slide that was very interesting. It had a lot of information on it, so I'm going to try to remember what was there.
Okay.
It was something about the survivors and the African-American patients seeking more pastoral care.
Oh,
and
mm-hmm.
the white patients seeking more, I guess, psychologists or some other type of counseling.
Yes.
Could you just talk a little bit more about those results and what implications that has for interventions or for the type of support that these patients have?
Yeah, I think that's a great question. Thank you for that question. So there has been some discussion that there may be a certain level of stigma associated with mental health concerns or seeking mental health. And so I've wondered if the racial variation that we see in where care is sought reflects that it's maybe a little bit more appropriate or acceptable to perhaps see a pastoral counselor versus a psychologist, which may feel a little bit more like labeling something as a mental health concern. I think another thing to consider, however, is for us to understand where patients receive their cancer care and whether or not they're in systems where it's easy to access a psychologist versus a system where that may not be the case. And so there may be other alternatives or pathways individuals seek. And I think the third thing is to really understand in the system who's recognized as having depressive symptoms, and if so, are they differentially recommended to go seek care versus situation where that's not the case. So I think there's still a lot that we need to fully understand. Thank you. Any other questions? Yes.
In the first paper, you looked at the worry factors, and age usually indicated as worry.
Yes.
But also income, I noticed. And you don't address insurance. How did you balance that? And
Okay, thank you for, I'm going to scoot back to. So what we did, and I appreciate that question. So for the different worry domains, we had a different set of covariates to being sure that we included covariates that made sense for that worry domain. So for instance, cost would have included a domain such as insurance and income. And so, so we did slightly vary the covariates depending on.
most people were insured.
A good number.
Hardship or
Most people were insured and still suffered the hardship. Yeah. And sometimes even among insured populations, the co-payments for certain treatments could still be very high. Yeah. But I really appreciate that question, because I think sometimes when we think about cost, we wonder if it's with individuals who have fewer financial means, but that's not the case across income groups. There's that significant impact and burden.
Thank you for a great presentation.
You're welcome.
On the slide that you had in terms of the economic hardship,
Mm-hmm.
and that was at the 1-year time point.
Mm-hmm.
So, did you have any data at the beginning, or did they go in with
It's a great question. Thank you. So unfortunately, we do not have the economic burden questions at baseline. So it's only a matter of including their income as possible surrogate, but we don't have that. Thank you. But I think that's important. Future studies.
So one of the slides you said, I believe it's at someone's at younger age, they experience less worry. I'm just curious as to what you consider younger age.
Thank you for that question. So all of the age brackets were compared to those less than or equal to 54 years. Mm-hmm. Yeah, that's a great question. Thank you for asking that.
Zip code that you had there, demographics, zip code information?
We probably do. We've never looked at the zip code information.
When you talked about in terms of income, possibly looking at zip codes in terms of what in that area, in terms of income, what how it would be, because there is some evidence in terms of people taking on the characteristics regardless of income. They take on the characteristics
Of where they live. Yeah.
is related to somebody.
Yeah, I think that's, yeah, I'm not familiar with any CanCourse paper that has looked at zip code, but that'd be very interesting. And I think even being able to, this would take a lot of work, but looking at income and looking at, I keep saying income, zip code, but looking at community infrastructure. So what's in that community that might help buffer having a diagnosis versus other communities that might have less resources. Yes, that's.
We talked about Wilmington, Tennessee,
Yes.
and the low mortality rate there. You delved into looking into what infrastructure they have and what might support. We can't hear the question.
Yes.
I'm sorry.
Uh-huh.
I was asking about how everyone enjoyed the way that when that quiz was done.
Ah, that's great.
But yeah, I was asking about Wilmington, Tennessee, and whether or not she had looked at the infrastructure or resources there that might improve health outcomes and lower mortality rates.
Yeah, so I have not as yet. It's on, I guess, the to-do list. I believe it is a county just outside of Nashville. I don't think Nashville is in that county, but I think it's a county just outside of Nashville. But it's an interesting question. Again, trying to understand for places that are doing well, what are some of the differences? Because I think sometimes when we think about disparities as well, we may identify barriers, and it's easy to think that the opposite of the barrier is what's needed for good outcomes, but I don't think we actually know that. Okay.
Well, thank you very much.
Okay, thank you for having me.
So if you have additional questions, Dr. Martin will be here for a few more minutes. And we really appreciate you attending our last spring seminar. We'll start back up in January. If you have not signed in or access, you sign in, we have the clipboard here. Thank you so much. You all have a wonderful day.
Thank you. Okay. You're welcome. Okay. Okay.